ขอบคุณครับ Good morning, ladies and gentlemen. Okay, I'm Bumanai Sampri from San Francisco Hospital. Today I will talk about the surgical choice that you choose to perform in the patient with perihilar cholangiocarcinoma. First of all, I think anatomy, precise anatomy is most important, just like Dr. Sala said. My teacher, Professor Pongrat, always said that if you don't have any 3D technology in your hospital, you will look at the CT or MRI and make it 3D in your head before you perform surgery. This is important. Don't make a technology limit your ability to surgeries. Okay? We know that cholangiocarcinoma is divided into many classifications. By anatomically, sometimes we divide into intrahepatic cholangiocarcinoma, perihilar cholangiocarcinoma, or intrahepatic colon with hilar involvement, and distal cholangiocarcinoma. Sometimes the tumor extends from the hilar regions. There's no, because I need pointer. Okay. Now today we talk about the cholangiocarcinoma with hilar involvement because of the procedure is the same, liver resections and bile duct resections. So if you have the patient with perihilar or cholangiocarcinoma with hilar involvement, when you decide to perform any procedures, you will look at many things: parenchymal transections, ductal margin, radial margin, vascular involvement or not. Okay. The standard procedure for perihilar cholangiocarcinoma is dual resections with bile duct or hilar resections. Sometimes we need vascular resection and reconstruction, and sometimes we need plus pancreatoduodenectomy. So, for resectability assessment, you will keep in mind 3 factors to evaluate the patient before you decide the operations. The first factor is the most important, patient factors, fit for surgeries or not, disease factors, distant metastasis or not. And for selections of the procedure, you will look at the local regional disease and the qualities of the liver. Okay, this is the step to select the procedures. The first one, you will look at the resection margins. The next one, you will look at vascular involvement. This is the disease factor, but I will lie it in the last one because of this is the most important to decide the operation. The third, the liver and lymph node metastasis. Okay, look at the first one, resection margins. When you decide to perform resection of perihilar cholangiocarcinoma, there's 2 resection margin, distal margin, okay? Just like Professor Ibata said, if the tumor extends to the pancreas, you need pancreatoduodenectomy plus, okay? And proximal margins. Margins divide into 2 types, radial margins and ductal margins. Ductal margins mean that tumor spread along the duct. And radial margins mean that tumor spread extend from the duct. Radial margin is periductal, parenchymal, and vascular. And ductal margin is proximal and distal. And our data show that radial margin and ductal margins had the same overall survival. And radial margin is the most common than ductal margin positive. So, when you decide to perform the operation in perihilar cholangiocarcinoma, not only ductal margin, you are concerned about the radial margin around the tumor. Okay? For radial margins, we use the data from intrahepatic cholangiocarcinoma. You need 1 or 2 centimeters from the tumor. For the periductal and vascular, you will peel off the tumor of the vascular structures. For ductal margins, please remove the video of my video. 1 centimeter from the tumor, you can avoid invasive carcinoma. 2 centimeters, you can avoid high-grade dysplasia or interstitial. This is the data from Nagoya. But this is the most important. To improve survival, you were concerned about is early case or advanced case. I will show you in the lymph node metastasis topic, okay? So when you decide to perform resection in perihela, the first step, margin, you will look at the distal margin, okay, 1 centimeter at least from the tumor, and you will look at the proximal margin inside the liver, okay, radial margins and ductal margins. Which side you can resect it safely and can achieve R0 resection, okay? First case, by the dilatation and the tumor is here. This is the tumor. Intraductal growth type along from hilar to ampulla regions. So in this case, you need HPD, okay? This is coronal view. We show you this is the tumors along from the hilar. Okay, you need HPD. This is the first step. Look at the distal margin first, PD in, plus or not. Okay, after that you will look at the intrapancreatic portion. This is intrahepatic hilar with hilar involvement, right? Intrahepatic colon with hilar involvement. Okay, the tumors here. You see the bile duct. This is the middle hepatic vein. The important way to decide the parenchymal transections, okay? In this case, the tumor is here, okay? When you look at the proximal margin, the first one is ductal margin, okay? You decide to cut 1 centimeter from the tumor enhancings. And for parenchymal margins, 1 centimeter from the tumor. If the middle hepatic vein is near the tumors, less than 1 centimeter, you need to cut the middle hepatic vein. Sometimes you call it extended right, okay, to segment 4B. Or if you need to cut clear resection, you must perform right trisectionectomy. Okay, so you decide to perform, okay, right hepatectomy or right trisectionectomy to increase the resection margin. For this case, okay, right side predominant tumor, right? The tumor is here, okay, enhancing here, not extend to the pancreatic portion, okay, you will decide intrahepatic portions, okay. So this is middle hepatic vein, right? So decide to perform cut the bile duct here to achieve R0 resection, and middle hepatic vein is around here. So if you want to achieve R0 resection, the bile duct is here, the parenchymal, if you preserve the middle, it's difficult to perform the resection. So in this case, it's suitable for right trisectionectomy in this case, okay? The same, you make it 3D in your head and decide the operation. For this case, bilateral bile duct dilatation and tumor is here. This is tumor. The portal vein is type 3, okay, that Dr. Sarat said. Tumor is here. So in this case, you see that left lobe atrophies and right lobe hypertrophy and right posterior is so enlarged. So in this case, this is right anterior, right posterior. Middle hepatic vein is here. If you want to achieve R0 resection, the transection line of radial margin is here. Sometimes it's impossible and it's difficult. So in this case, left trisectionectomy with hilar resection is reasonable. Okay. So the last one, this is middle hepatic vein, most important. The tumor inside the bile duct, intraductal growth type. Okay, this is the CBD. It's the tumor not extend to the pancreatic portion. This is portal vein. Okay. In this case, the tumor here grow intraduct. We decide to perform left side. However, if you perform left hepatectomy, you preserve the middle hepatic vein. It's difficult and risky to get R1 resection. For extended hepatectomy, okay, it's okay, but left trisectionectomy is too much. So in this case, we decide to perform just like this, extended to segment 5 and preserve the middle hepatic vein in segment 8. This is the procedure we use nowadays in my centers, okay? This is the resection margin, okay? Most important. The first one is most important. Distal margin, proximal margin, radial margin, and ductal margins. Okay, after you decide to perform left or right side liver resection, the next step is vascular involvement. Vascular involvement, you must concern to point it's safe to perform resections, and it's got a benefit, oncological benefit for the patient. There's a two vascular structure you must concern, portal vein and hepatic artery. Nowadays, portal vein resection and reconstruction is acceptable worldwide, but artery, it's, I think, debatable nowadays, Western country and Eastern country. For example, in this case, this is middle hepatic vein, okay? The tumor is here. Okay, this is right side predominant tumor, right? This is portal vein. You decide to perform right side liver, and you can see the tumor involves the right portal vein and the bifurcation. So in this case, you decide to perform extended or right dissectionectomy plus portal vein resection and reconstruction. The next case, okay, this is a portal vein, okay? The tumor is here. This is right side predominant tumor, right? And the portal vein is involved by the tumor here. So in this case, this is middle hepatic vein. Proximal, distal margin is okay. For proximal margin, you need here to perform, to get R0 resection. But the middle hepatic vein is near the tumor. At least you resect the 4B or right dissectionectomy. For portal vein resection and reconstructions, the most important point is that you can control the proximal and distal part. In this case, you must evaluate the proximal control or the distal control here. You can control it safely before you cut the portal vein, and you can perform reconstruction it safely. This is the most important point, okay? In this case, this is the middle hepatic vein and tumor in the left side. Okay, this is portal vein. This is the tumor here, not extend to the pancreas, okay, and middle hepatic vein here. In this case, you can see the tumors here and the middle hepatic vein here. Okay, the liver resection maybe extend to the segment 5 and cut here, but the tumor involved by the portal vein, you need to perform portal vein resection and reconstruction. Okay, in this case, this is middle hepatic vein, okay? This is the tumor here. This is portal vein. This is right posterior. This is right anterior. In this case, the tumors involve the right anterior duct and involve the confluence of the portal vein. In this case, it's a difficult case. We decide to perform left dissectionectomy with bile duct resection, with portal vein resection and reconstructions. You need embolization before. And this case is difficult case, okay? I said to you that portal vein and artery. This case, it involves both portal vein and artery. You see, this is portal vein, the tumor is here. And this is the right hepatic artery, you see. In this case, it involved by the tumor, both hepatic artery and portal vein, but the tumor is left side predominant. You need to perform left hepatectomy. This is middle hepatic vein. Perform left hepatectomy, hilar resection, portal vein resection, and hepatic artery resection and reconstruction. Okay? This is first resection margin. Second, vascular involvement. The third one is liver resection. You decide dissectionectomy, left dry, right dry, extended, something like that. The most important point, the next point is liver. The patient's liver allow you to perform that operation or not. This is important. We always two category, quality and quantity. Quality, you will perform drainage before surgery. If the bilirubin decrease properly, less than 2 by Japanese style, but in my centers, maybe less than 5 be acceptable if there's no complex surgery and the patient fit for surgery. Okay, you will evaluate the quality of the liver, and after that you evaluate the quantity, the volumes of the livers. We know that this is the general principle, but for perihilar cholangiocarcinoma surgery, we need more than 40% of the future liver remnant volumes to perform safely liver resections, okay? The last step, you will look at the lymph node metastasis. This is the most important point to decide, to judgment the procedures. Why? Because of lymph node metastasis in our series and all over the world, more than 50% of the patients with perihilar cholangiocarcinoma involved by the lymph node, and the outcome is not good. For our series, margin and node is the poor prognostic factors, and we think that if the patients have node positive, resection margin is matter or not. Okay, so we analyzed the data and published this paper, and we found that for node negative, R0 and R1, it's different in survival. But for node positive, R0 and R1, it's not different. This is the most important point. Because of it, you decide to perform trisectionectomy, portal vein resection, artery resection, but the patient have lymph node metastasis. Sometimes it's much more price to pay for the patients. And the most important is lots of the patient experience post-hepatectomy liver failures. And we found that not only short-term survival for the patient, but also post-hepatectomy liver failure will impact the long-term survival. You can see the patient with post-hepatectomy liver failure had poor long-term survival compared to the patient without post-hepatectomy liver failure. So nowadays, my centers apply the balance strategies. We will balance about oncological benefit. You want to achieve R0 resections by left trisectionectomy, right trisectionectomy, vascular resection, and reconstruction, but you are concerned about the post-operative harm because of post-hepatectomy liver failure impact long-term survival. Okay, so for conclusion, the choice of the operation, the first one, you look at the margin, distal margin, proximal margin, and radial margin, ductal margin for proximal or distal margin. After that, you will look at the vascular involvement or not, okay, its benefit and feasibility to perform vascular resection and reconstruction. And you look at the livers of the patient, it allows you to perform that operation. And the last step is most important step, lymph node metastasis or not. Nowadays, I think we don't talk about the procedure in lymph node metastasis. We talk about the neoadjuvant before surgery in this kind of patient, okay? Okay, this is my talk today. Thank you for your attention.